مساء الخير على حضراتكم. بشكر حضرتك على التقديم. بشكر الأخ العزيز أستاذ دكتور أسامة حسين على دعوتي، والحقيقة بشكره إن أنا جيت بورسعيد، يعني عشقي، يعني أنا بحب أجي بورسعيد وبحب أهل بورسعيد وبستمتع الحقيقة، يعني فأي حاجة أنا جاهزة على طول، يعني يسعدني ويشرفني. الحقيقة أنا اخترت التوبيك بتاع الريكتس لأن هو يهم ناس كتير، مش بس إحنا كبيدياتريك اندوكرينولوجيستس، لا أعتقد يهم البيدياتريشنز، وداخل فيه ناس كتير، يعني النفرولوجي والاندوكرينولوجي والبيدياتريكس والنيوتريشن، ناس كتير قوي مشتركة في موضوع الريكتس، فحسيت إنه ممكن يكون good raw material for open discussion. أنا سميتها a new face of an old story، لأن إحنا طبعا الريكتس حاجة مش جديدة علينا، بس كل شوية بيتغير الفيسز بتاعته. And let me open the scene by this photo of a rachitic child, and when facing a child with rickets, these are the questions that come to our mind. Is it still that common? Which type of rickets? How to diagnose? Which type of vitamin D to choose? To treat for how long? Is it long lasting or some time? Give calcium or not? And what is the follow-up plan? And these are the points that I will try to cover in this talk, and when to start vitamin D prophylaxis. So I think when dealing with a case of rickets, it's a challenge being accepted, because rickets is not that easy as we might think. Let me start by a very classical story of a 7-month-old infant who presented with tetany, carpopedal spasm. The baby was short, minus 2.6, underweight. The birth weight was normal. As you see, there is craniotabes, bowing, and vitamin D prophylaxis was not given to the infant or mother during pregnancy. What are the suggested labs? What would you like to do for this baby? Tetany, carpopedal spasm? Yes, thank you. Calcium, phosphorus, alkaline phosphatase, vitamin D, and PTH. And this is the panel that we do for any hypocalcemic baby. You can see here that the calcium is very low, phosphorus is low, alkaline phosphatase is very high, 25 hydroxyvitamin D is low, and the parathyroid hormone is high, and this is secondary hyperparathyroidism due to hypocalcemia. What's your diagnosis? Very classical case. Nutritional rickets. And you can see here the signs of active rickets clear at the epiphysis, and here this is a fracture and rickety rosary, as you see here. So I think that rickets is an old story which started long time ago. So let me tell you the short history of vitamin D. The history of vitamin D started when these 3 scientists were exploring vitamin D and vitamin D deficiency. And it went through several steps until 2008, when there was a recommendation of giving 400 international units to infants to avoid rickets. And surprisingly, 1 billion people have low vitamin D. Nutritional rickets is prevalent in breastfed infants, and therefore we have to supplement, and low vitamin D is prevalent among healthy children and adolescents. So it's a disease of infants, children, and adolescents. And vitamin D deficiency is a growing worldwide problem. You can see here the areas showing vitamin D inadequacy, and if we focus on Africa, where we live, Africa is the most prevalent. 80% have low vitamin D, which is very high. And of course, we know that sun is the main source of vitamin D. My question to you, is it only a matter of sun exposure? Yes or no? Who says yes? Only sun, or are there other factors? Yes, there are other factors. And this is a research conducted at Ain Shams University that proved that a lot of factors affect the occurrence of rickets. It was published in Pediatric Research. And we concluded that the prevalence of vitamin D deficiency presenting as rickets is prevalent worldwide. Insufficient exposure to sun, vitamin D, calcium are the main causes. However, and this is the new thing, genetic predisposition, severity, clinical course is caused by vitamin D receptor gene polymorphism. So there is genetic susceptibility to rickets, and you can see this in Europe. There is no sun and they do not have rickets because they do not have genetic polymorphism or susceptibility. And these were the genetic polymorphisms that we found, denoting that Egyptians are more liable to vitamin D deficiency in spite of having a lot of sun. So rickets is failure of mineralization of growing bone or osteoid tissue, and serum inorganic phosphate is an important in pathophysiology of rickets. Nutritional rickets, of course, is the most common cause of rickets. And please remember that all types of rickets is due to hypophosphatemia, whether calcipinic rickets or hypophosphatemic rickets. Because in case of calcipinic rickets, there is increased parathyroid hormone, which leads to loss of phosphate in urine, chronic hypophosphatemia, impaired differentiation of chondrocytes in the growth plate. What about phosphatemic rickets? There is loss of phosphate of urine from the beginning. So the pathophysiology of rickets is hypophosphatemia, whatever the type of rickets. And of course, there is a vitamin D based calcium endocrine system. When the calcium goes down, there is increase in the vitamin D and parathyroid hormone, leading to normalizing in the blood calcium level. And if you look at the vitamin D metabolism, you can see that sun acts on 7-dehydrocholesterol forming vitamin D3, which passes to the liver, and 25 hydroxylation occurs, and then to the kidney, where 125 hydroxylation occurs, ending in the active form of vitamin D. And please remember that the parathyroid hormone is important in the 1-alpha hydroxylation step in the kidney, and therefore, if deficient, there is affection of vitamin D activation. So our goal is not only to diagnose rickets, our goal is to diagnose the type of rickets, because the treatment varies a lot, as I'm going to show you. So when we say rickets type, which card would you like to play with? If you need to diagnose the type, which is the most important in these 3 cards? Is it the clinical features, radiology, or lab? Who will say the clinical feature is the most important? Okay, no one. Radiology, is it the most important to diagnose the type of rickets? Okay, what about the labs? Who will say the labs? Yes, thank you very much. Of course, the labs is the most accurate, because we all know the skeletal features of rickets, but unfortunately it is not specific for a certain type of rickets. Also, radiological features. We see the active signs of rickets, but it does not specify a certain type of rickets. But when we do the labs, it's the most important to diagnose the type of rickets. Withdraw calcium phosphorus alkaline phosphatase, 25 hydroxyvitamin D, sometimes 125, which is very expensive and not routinely done, and the parathyroid hormone. And these are the labs that can differentiate the different types of rickets. And please remember that vitamin D, 25 hydroxyvitamin D, is the key diagnostic test for vitamin D deficiency or insufficiency. And these are the reference guidelines from various organizations. We follow the Endocrine Society guidelines to diagnose vitamin D deficiency, insufficiency, or sufficiency. And please be aware from the overdosing, because if the vitamin D exceeds 100 to 150, this is an overdose, and you're going to have suppressed parathyroid hormone. Now, going to the treatment of vitamin D deficiency rickets, our aim is to correct clinical, biochemical, and radiological abnormalities and to restore vitamin D reserve. Now, which dose and which approach do we use? Is it the daily dose or the single dose when using cholecalciferol? And calcitriol and alpha-calcidol are not suitable for treating nutritional rickets. Please remember this. Don't give the active form of vitamin D in cases with nutritional rickets. They have short half-life and bypass the natural physiological synthesis of vitamin D. So we use the natural types of vitamin D in cases of nutritional rickets. What about the calcium supplement? Some people give calcium, others do not give calcium. It may speed up the healing, but its use in asymptomatic patients is controversial. So, which type of vitamin D would you like to use? If we are dealing with nutritional rickets, who would like to give vitamin D3 and who would say vitamin D2? Who would like vitamin D2? Okay. Who would like to give vitamin D3? Yes, thank you very much. Of course, we have to vote for vitamin D3. Vitamin D2 is made from ultraviolet irradiation, ergosterol, and vitamin D3 is made from 7-dehydrocholesterol by the effect of sunlight. And please remember that vitamin D3 is 3 times more effective than vitamin D2, and it has a longer half-life. So if you look at this curve, you can see that at first both of them are absorbed. Vitamin D2, which is in green, goes down in its level very quickly, while vitamin D3 stays in the blood for a long time, up to 30 days. So it is recommended to use vitamin D3 in treating nutritional rickets rather than vitamin D2. And this is the global consensus recommendation for management and prevention of vitamin D deficiency rickets. And you can see here a lot of societies shared in putting the guidelines for managing nutritional rickets, because it's really not simple, with European society being on top of the list. And these are the treatment doses for nutritional rickets. You can see vitamin D3 is the recommended type, and you can see either daily dose for 12 weeks or single dose, and you can see the doses here according to each age group. You have to ensure that calcium is adequate, whether by diet or giving calcium if the calcium is low. And this is the maintenance therapy, and it's very important to give maintenance therapy when the labs normalize, and this is for 1 year, because if you stop the treatment, the vitamin D is going to go low again. Another question, to give or not to give calcium. This is a very controversial point. You have to ensure a daily calcium of 500 milligrams a day. If there is tetany or convulsions, we start by IV calcium and then shift to oral. Some use calcium therapy for 1 to 2 weeks to provide elementary calcium, even in the absence of hypocalcemia. For me, I do not use calcium except if the calcium is low. I do not recommend giving calcium in every case of rickets except if the calcium is very low or borderline. What about the sequence of lab normalization after treating rickets? You can see here calcium and phosphorus normalize after 6 to 10 days. The parathyroid hormone normalizes after 1 to 2 months. Alkaline phosphatase takes up to 3 months. So you have to reassess the labs after 12 weeks of treatment. So don't rush. Some people remeasure the labs after 1 month. Don't expect any change. Don't assess before 3 months. Calcium, phosphorus, alkaline phosphatase. Now, another question, nutritional rickets. For how long shall we treat? There are 2 schools. One of them is to treat 12 weeks with doses according to the age that I showed you in the previous table. Another is until radiological healing is established and the alkaline phosphatase is normal. I go with the first one because you have to continue the 12 weeks, otherwise the labs will go in a different way. So better to continue treatment for 12 weeks. And whatever regimen you prefer, you have to continue on maintenance therapy for 1 year to avoid relapse. And don't forget the natural treatment for rickets: exposure to the sun, half an hour a day, and nutrition, as you see. And because an ounce of prevention is worth a pound of cure, it's very important to give vitamin D prophylaxis. And here you can see suggested intake and upper limit offered by the Journal of Clinical Endocrinology and Metabolism. These are the doses. And we have to start vitamin D from day 1. This is very important. Don't wait. Start from day 1. And this is the recommended calcium intake, again published in the Journal of Clinical Endocrinology and Metabolism. But as I told you, if the calcium is normal and the baby is eating well, you are not obliged to give calcium. Maternal vitamin D intake is very important. It's very important to supplement pregnant ladies with 600 international units of vitamin D in addition to adequate sun exposure. And again, the baby will be given vitamin D from day 1. Now, let's go back to the case that I started with you. What is the suggested treatment? This is vitamin D deficiency rickets. This is nutritional rickets. Vitamin D2 or D3? Thank you very much. Yes, we gave IV calcium because the baby came with tetany, and then we shifted to oral calcium in addition to vitamin D. And thank you for answering the question. We gave vitamin D3. This is the recommended type of vitamin D. Now, yes, nutritional rickets is the most common, but is it always nutritional or not? Defining the cause of rickets subtype is very important because sometimes the treatment is different. Nutritional rickets is unlikely if there is a strong family history of rickets, associated features like alopecia and hepatomegaly, severe skeletal manifestations, poor response to traditional vitamin D3. And remember, radiology is not helpful at all to differentiate the different types of rickets. We rely on the labs, calcium phosphorus alkaline phosphatase, parathyroid hormone, and vitamin D. Now, looking at the rickets subtype, we have nutritional rickets, we have selective 25 hydroxylase deficiency if the problem is in the liver, vitamin D resistant rickets type 1 if the problem is 1-alpha hydroxylation, and finally, vitamin D resistant rickets type 2 if the problem is in the receptor. And finally, we have the hypophosphatemic rickets if the problem is losing phosphate in urine. Now, let's go to the story of this boy. This is a Saudi boy. He came to me with short stature, bowing, waddling gait, bone pain. Parents are consanguineous, first cousin, palpable sagittal suture. He has a small dental abscess. He's very short. He does not have the typical features of rickets like widening or rickety rosary. And these are the x-rays of the boy. You can see the bowing is very clear. Some active signs of rickets. He has sagittal suture being prominent and a little bit of silver beaten appearance, as you see here. Now, the calcium is not very low. It's normal, but on the low side. The phosphorus is very low. Alkaline phosphatase is very high. 25 and 125 vitamin D are normal, and the percentage of tubular reabsorption of phosphate is very low, meaning that phosphate is lost in urine in large amount. The parathyroid hormone is in the high normal because calcium is in the low normal. Blood gases is normal. What's your diagnosis? Yes, can we say nutritional rickets? Is this nutritional? Of course not. He's far above the age of 3 years. It's not the typical signs. The calcium is normal, vitamin D is normal, but the phosphate is very low. This is hypophosphatemic rickets because the most important thing is losing phosphate in urine, and the calcium here is normal. This is very important. When you have low phosphate, don't forget to measure PTH, either high, knowing that this is abnormalities in vitamin D or calcium deficiency or hyperpara. If it's normal or low, measure urine phosphate. If low, this is decreased phosphate intake or phosphate malabsorption or increased extrarenal removal of phosphate. If high, we don't have, unfortunately, in Egypt, FGF23 to discriminate between hereditary types of hypophosphatemic rickets like XLH. And XLH or X-linked hypophosphatemic rickets occurs due to excess FGF23. And you can see the clinical features, and the most important thing here is the low serum phosphorus, high phosphate in urine, and the calcium is normal. And it occurs at an older age, and of course parents are consanguineous. And this is the conventional therapy giving phosphate, active form of vitamin D. Can we give vitamin D3 in such a case? Yes or no? Who says yes? Thank you very much. No one said yes. We do not give vitamin D3. This is not nutritional. Here we have to give alpha calcidol or active form of vitamin D. And there's a very recent radical treatment for XLH, which is the burozimab, binding to FGF23. Another case is 14-month-old girl. Parents are consanguineous. She has motor delay, failure to thrive, broadening in the wrists, as you see. The calcium is low, the phosphorus is low, the alkaline phosphatase is high, and the parathyroid hormone is high. And if you look accurately, the 25 hydroxyvitamin D is normal and that 125 is low. So this is vitamin D dependent rickets type 1 due to defect in 1-alpha hydroxylation, which converts 25 to 125 dihydroxy. And that's why the 25 is okay and the 125 is low. And the treatment again is alpha calcidol and calcium. So this is what happens in type 1A vitamin D dependent rickets. This is the block, lack of conversion of 25 to 125. So 25 is going to be normal or high and the 125 vitamin D will be low. The other type is type 1B, defect in 25 hydroxylation. This is the block. So we're going to have low 25 and low 125 because the block is early. Type 2 is due to defect in the receptor. So we're going to have very high levels of 125 dihydroxyvitamin D. And in all of these types, the treatment is alpha calcidol. You cannot give the vitamin D3. This is vitamin D dependent rickets type 1B, and this is a spot diagnosis. What's your diagnosis? Alopecia, bow legs, normal vitamin D 25, very high 125. What's your diagnosis? We see it. Yes? Vitamin D resistant rickets type 2. This is a spot diagnosis. Whenever you have a child with rickets, alopecia, very high vitamin D, this is vitamin D resistant rickets type 2, and of course he will need very large doses of vitamin D active form and calcium. Now let's put it together. This is a summary of all types of vitamin D, whether nutritional or genetic types, and choosing the correct preparation of vitamin D is very important. When you have nutritional rickets, you have to give vitamin D3. When you have other types of rickets, you have to give alpha calcidol or calcitriol, which is the active form of vitamin D. And of course, the dose varies between neonates, children, adolescents, and adults. So I hope you were able to see the multiple phases of rickets, and I hope you agree with me that rickets is not that simple. It's really complicated and difficult to diagnose. And when facing a case of rickets, don't forget to think twice. It's not always straightforward. It's not a matter of giving just vitamin D and calcium. You have to diagnose the type and treat accordingly. My conclusions here are rickets is an old enemy, but still there with many faces, as you've seen. Nutritional rickets is the most common type of rickets, but other types should be excluded. Lab parameters are essential to differentiate. Radiological findings cannot discriminate between the different types of rickets. Vitamin D3 is the treatment of choice in nutritional rickets. Alpha calcidol or calcitriol is the treatment of choice for other genetic types of rickets. Nutritional rickets is preventable, so don't forget to give vitamin D prophylaxis from day 1, vitamin D3. The knowledge of vitamin D physiology, metabolism is essential to understand the causes of rickets and the proper management. And of course, it's not only rickets. Rickets is only the tip of the iceberg. There is a lot of diseases and disorders being related to vitamin D deficiency. And we sometimes take the sun for granted. حاجة موجودة وببلاش. بس it's really a gift of nature. Sun is full of health and we have a lot of sun. And this is a message from the sun. Take vitamin D, it's for free. You don't have to pay. Staying half an hour in the sun is very beneficial. And sometimes in Egypt, for example, the sun tells us you're going to get vitamin D whether you like it or not. We have a lot of sun, we are exposed to the sun, so we're going to have vitamin D. بالعافية كده عندنا في مصر. بحب أحط الصورة دي كل ما أجي بورسعيد، عمداء بورسعيد اللي بحبهم وبعتز بالصورة دي جدا. I always feel at home. الحقيقة دايما بحس ان انا في بيتي ووسط اهلي، درجة عالية من الترحاب والحفاوة ويعني feeling at home. بشكرهم جدا وبشكر حضراتكم، وشكر خاص للأستاذ الدكتور أسامة حسين على الدعوة الجميلة. اتشرفت وسعدت، بحب دايما أكون موجودة معاكم. بشكر حضرتك. Thank you very much for the kind invitation و hospitality. We're glad to join 14th PENSIC. Thank you very much for your attention.
شكرا لحضرتك أستاذتنا الدكتورة رشا طريف، متألقة دايما كالعادة ومحاضرة ممتازة وجميلة ودايما منورانا في كل مكان.
ميرسي لحضرتك.
طبعا في البداية أحب أتوجه بالشكر لأستاذنا الأستاذ الدكتور أسامة حسين. أسامة ماشي، اتفضل يا دكتور شاكر. دكتورة شيماء.
Thank you, Doctor, for your nice presentation. In case of rickets with bony deformities, bow legs or whatever the cause, it's يعني treatment with vitamin D will cure the deformity, or we need to share the orthopedic team, and over how long it will be corrected if no surgical treatment will be needed. Thank you.
Thank you very much. الحقيقة very important question. يعني it's very important to work in a team، خصوصا لما بيبقى في deformities. احنا we would like to share مع ال orthopedic surgeons. بس طبعا في نقطة مهمة قوي، ان احنا بنطلب من البيشنت ان ما يحصلش اي surgical interference الا لما الالكالاين فوسفاتيز يرجع للنورمال، لان احنا ودي شفناها لما بيتصلح surgically والالكالاين فوسفاتيز is very high بيحصل recurrence للديفورميتي تاني واسوأ من الاول كمان. فاحنا كبيدياتريشنز محتاجين تو نورماليز اللابز الاول، وهنعيد بعد 12 اسبوع لما نلاقي الالكالاين فوسفاتيز والكالسيوم والفوسفورس بقوا طبيعيين، ساعتها وي ريفير باك للاورثوبيديك سيرجن. حاجه تانية ان الحاجات البسيطه قوي لما بيبقى في مايلد ديفورميتي احيانا بتتصلح وما بنحتاجش الاورثوبيديك سيرجن، بس مع السيفير ديفورميتي لا، احنا وي نيد تو نورماليز اللابز الاول وبعدين نبعته للاورثوبيديك سيرجن، وبرضه مطلوب منه يكمل العلاج لمدة سنة maintenance therapy عشان ما يحصلش recurrence تاني. اتفضل
دكتور، ممكن سؤال؟
اتفضلي.
هي حالات بصراحة واجهتني. القصة بتبدأ بنيوتريشنال ريكتس بكل البيكتشرز بتاعتها من اللاب. أخدنا الوقت بتاعتنا وصلحنا كل حاجة. بعد 3 شهور لما بعيد اللاب بلاقي الفيتامين دي خلاص بقى نورمالايز. الكالسيوم يوجوالي من الأول بيبقى نورمال. الفوسفيت كان نورمال بقى هاي، والالكلاين فوسفاتيز ستيل هاي. دي كيس. وبقعد اريبيت اللاب كل 3 شهور، والبرس هرمون بقى نورمال. بريبيت اللاب كل 3 شهور برضو الفوسفيت مش عايز ينزل ولا الالكلاين فوسفاتيز. وحاله ثانيه الالكلاين فوسفاتيز هو اللي بيبرزست لغايه دلوقتي. البيشنت طولت معايا والجروس بقى جميل ومفيش اي مشكله. انا عملت كدني فانكشن، عملت ابدومينال الترا ساوند، انا مش عارفه هو ليه الالكلاين فوسفاتيز بيبرزست وهو مش هاي قوي. يعني يعمل مثلا 470 بعدين ينزل 360 بعدين يبقى 400 بعدين 325 بعدين 370. انا عماله ريبيت وهو تمام. نفس البيكتشر دي معايا. فانا مش عارفه اعمل لها ريفيرال ليه، فين هي المشكله فين. بس
تمام.
في بس حاجه في الكيسز دي ان هم كانوا كون ميلك بروتين الرجي.
تمام.
بس دي المشترك فيهم.
تمام. ثانك يو فيري ماتش. برضو ده سيناريو اللي حضرتك قلتيه احنا كلنا بنواجهه، لان مش كل الحالات بتمشي زي ما احنا عايزين بالظبط. يعني خليني اقول اول حاجه انه في ناس بيعلق معاها الالكالاين فوسفاتيز شويه. انا معظم الريفرنسز بتقول انه بياخد حوالي 3 شهور تو نورماليز. في ناس بتقعد اكتر من كده، يعني في ناس ممكن تقعد 6 شهور. وفي نقطه عايزه انوه عليها، مش كل المعامل بتحط الريفرنس رينج المظبوط حسب السن. يعني انا في جروينج تشايلد الالكالاين فوسفاتيز لغايه 400 نورمال، ممكن يبقى هو حاطط لك في المعمل ان ده النورمال لغايه 200. انا ماليش دعوه. لو اقل من 400 this is okay. فدي نمره واحد، مش هعتبره عالي حسب الريفرنس رينج. الطفل غير الادوليسنت غير الادلت. تمام. يعني انا لو هعتبر فوق 200 عالي في واحد كبير، لا في طفل ده عادي. this is not high. فجرو خصوصا لو growing child، يعني في مرحله الجروث الالكالاين فوسفاتيز is normal to be high. احيانا كمان بعض الاطفال بيبقى الريزيرف اوف فيتامين دي كان قليل جدا، الى درجه ان انا ايوه لما اديت علاج الفيتامين دي ابتدى يبقى sufficient بس لسه ما عملش الابروبريت ستورز اللي تخلي اللابس تبقى بيرفكت 100%. فانا في الحاله دي بطول المينتننس دوز، وعشان كده انا نوهت ان احنا مهم حتى بعد ما اللابس تبقى طبيعيه ان انا اكمل لمده سنه، لاني انا لو وقفت هما ما عندهمش ستور اصلا فهينتهي بيهم الامر ان يقع الفيتامين دي ونبتدي السايكل من اول وجديد. فدي اهميه المينتننس. قصه بقى ان الفوسفيت يعلى برضو دي عادي، ده فايندنج احنا بنشوفه مفيش منه اي مشكله، انا بتبقى ده عادي برضو ان جروينج تشايلد كان عنده ريكت. ساعات الريسبونس بيبقى مبالغ فيه سنه، يعني الجسم الباراثايرويد بتحاول ترجع الدنيا باك تو نورمال فبيحصل شويه خلل، فبيبقى من ضمن الحاجات ان الفوسفيت ساعات يحصل فيه الموضوع ده، لكن ملوش اي افكت. انا ما يعنيني ان الكالسيوم ما يبقاش واطي والالكالاين فوسفاتيز يرجع باك تو نورمال. انما حكايه ان الفوسفيت احيانا الجسم بيرياكت بان a little bit of high phosphate this is not a problem at all. بس السيناريو اللي حضرتك حكيتيه بشكرك لان هو فعلا احنا بنشوفه، مش كل الحالات بتمشي على السطر بالظبط زي ما احنا عايزين. ثانك يو فيري ماتش.
شكرا جدا لحضرتك.
ميرسي. في حد؟
شكرا جزيلا على المحاضره الرائعه دي. انا كنت عايزه اسال حضرتك سؤال بنتساله كتير قوي، امتى اعمل ريفير للاورثوبيديك لطفل عنده اي بون ديفورميتي، سواء نكني سواء بولج، اي مشكله في البون عامه، امتى اعمل ريفير للاورثوبيديك والاورثوبيديك يتدخل؟ امتى اقول له لا احنا هنقعد نتابع بالتحاليل وتاخد الفيتامين دي والكلام ده، وامتى اقول لا ده لازم يرجع للدكتور؟ السن والعلاج كمان، يعني في ناس تقول لا المفروض ياخد مثلا الفيتامين دي شهر ويريح اسبوعين وبعدين يرجع يكمله عشان الرينال امبيرمنت والكلام ده، في ناس تقول لا ممكن ناخد 3 شهور نكمل عليه ونرجع نريح شهر. انا مش عارفه امتى وامتى بصراحه. شكرا جزيلا.
ميرسي ليك. طبعا هو يعني سؤال little bit broad، بس لو هنحط قاعده عامه، اولا اي طفل عنده severe deformities انا محتاجه الاورثوبيديك سيرجن معايا whatever سنه ايه. يعني لو انا عندي طفل الديفورميتيز واضحه فيه جدا وزياده عن اللازم وعنده skeletal abnormalities جامده انا محتاجه الاورثوبيديك سيرجن. النقطه الثانيه، انا مش هقدر ولا هجرؤ ان انا تو ريفير للاورثوبيديك سيرجن الا زي ما قلت لحضراتكم لما اللابس ترجع كومبليتلي نورمال. يعني انا حتى لو الطفل ده عنده ديفورميتيز واضحه جدا جدا بس الالكالاين فوسفاتيز 1000، لا انا ما اقدرش ابعته للاورثوبيديك سيرجن دلوقتي لان هو مش هيقدر يلمسه، اذروايز الديفورميتيز هترجع تاني. فانا محكومه بحاجتين، اللابس والكلينيكال فيتشرز اللي عندي. اول ما اللابس تبقى نورمال انا اقدر تو ريفير للاورثوبيديك سيرجن في اي وقت. والحاجه الثانيه، لو انا عندي severe deformities وقدرت اظبط اللابس وارجعها back to normal تاني I can refer to the orthopedic surgeon. انما لو انا لسه اللابس بتاعتي ملخبطه هو مش هيقدر يتدخل، بل بالعكس بقى ده ساعات الموضوع يبقى معكوس. ساعات دكاتره الاورثوبيديك سيرجري بيبعتوا لي الحالات الاول يقولوا لي ظبطي اللابس ورجعيها لنا تاني نشتغل فيها العمليه، واحيانا ما بنحتاجش العمليه لو هي مايلد لان تصليح الميتابوليك ايرور بيحسن كتير. فهي ملهاش سن محدد اقول والله عند سن كذا انا هبعته، لا هي محكومه بالديجري اوف ديفورميتيز ومحكومه بان انا ارجع اللابس الاول باك تو نورمال وبعدين ابعتها بعد كده للاورثوبيديك سيرجن. والتيم ورك مهم جدا طبعا.
شكرا لحضرتك.
ميرسي لحضرتك جدا، متشكره.
بحب اتوجه بالشكر للاستاذ الدكتور اسامه